Good morning, Sino.
Good morning.
Good morning, David.
Anna, good morning. Mohan sir, good morning, sir.
Good morning.
Good morning. Good morning. సరిపోద్దో లేదో తొందరగా మొదలు పెట్టాలి ఈరోజు.
సరిపోతుంది సార్. 8కి మొదలు పెడతాం సార్.
అలాగే అలాగే. డేవిడ్ సార్ ఇష్టం, నీ ఇష్టం నా ఇష్టం కాదు.
అవునవును.
ఫైనల్ గా మీ ఇష్టమే సార్. స్టార్ట్ చేద్దామా?
మనమంతా నిమిత్త మాత్రం సీను.
ఎవరు నిమిత్త మాత్రలు?
నేను సీను అందరూ నిమిత్త మాత్రమే. ఓన్లీ ఐఎస్సిసిఎం ప్రెసిడెంట్ ఒక్కడే టాప్.
ఐఎస్సిసిఎం ప్రెసిడెంట్ కి దేనికి సంబంధం ఏంటి సార్ అసలు?
నువ్వేగా నా ప్రెసిడెంట్.
ఎస్సిసిఎం గైడ్ లైన్స్ కదా, సర్వైవింగ్ సెప్సిస్ గైడ్ లైన్స్ కదా.
దానికంటే మీరు ఇంకా నేషనల్ కౌన్సిల్ మెంబర్ కదా, ఇంకా పవర్ఫుల్ మీరు.
సార్ ఎగ్జిక్యూటివ్ మెంబరు
గైడ్ లైన్స్ క్యాన్సిల్ చేయగలిగిన అథారిటీ కూడా మీకు ఉంది సార్.
ఎవరో కింద ఎవరో సార్ ఇంకా 2 minutes ఉంది. థ్యాంక్ యూ
సార్. మోహన్ సార్, మీరు నేషనల్ ఎగ్జిక్యూటివ్ మెంబరు ప్రెసిడెంట్ అంటే అక్కడ షాక్ తింటారు సార్. ఒకసారి ఏదో ఇట్లానే మీటింగ్ అయితే ఐ టోల్డ్ అవర్ హైదరాబాద్ ప్రెసిడెంట్ టోల్డ్ లైక్ దిస్ అది అని అంటే, బాబు అని చెప్పారు, ఒకటే ఒక ప్రెసిడెంట్ ఉంటాడు, హైదరాబాద్ కి చైర్మన్ ఉంటాడు, ప్రెసిడెంట్ ఉంటాడు, నేషనల్ లెవెల్లో ఒకటే ఒక ప్రెసిడెంట్ ఉంటాడు, ఫీల్ అయ్యాడు ప్రెసిడెంట్.
సంబంధం లేదు, మా ప్రెసిడెంట్
లోకల్.
అన్నా చదివావా నువ్వు డేవిడ్? చదివావా మొత్తం గైడ్ లైన్?
ఏం చదవటం అన్నా, మీరు చెప్తారు కదా ఈరోజు.
కోవిడ్ బిజీ ఉందా? కోవిడ్ ఎలా ఉంది?
కోవిడ్ లేదన్న, కోవిడ్ ఏం లేదు.
ఓకే,
మీకుందా?
లేదు ఏం లేదు.
లేదు కోవిడ్.
ఓకే అన్న, 8 అవుతుంది.
గుడ్ మార్నింగ్ all of you. Today from Citizen Hospital, Dr. Srinivas Jekinaboyina and Dr. Mani Prasad Reddy and Dr. Pratyusha, we are going to talk on surviving sepsis, the new guidelines recently released by the Surviving Sepsis Campaign group. So they are going to compare the previous guidelines and the new guidelines, what are the changes and how they are helping in treating patients with sepsis and septic shock. So I request Dr. Jekinaboyina and Srinivas to introduce the other two speakers and start the presentation. Srinivas.
Thank you, sir. Thank you for giving the opportunity for us. And these are surviving sepsis guidelines for will try to complete, which is the most important, and this has come after 2016, and we have a small update in 2019, 1 hour bundle update. Other than that, the most of the guidelines were given in 2016. Here Dr. Mani Prasad Reddy, who is a DNB critical care resident first year, and also Dr. Pratyusha, she is doing IDCCM. So they will also join. First, the sequence will be, first I will be doing few slides, then Dr. Mani will be doing few slides, Dr. Pratyusha will do few slides, followed by myself. We have a few slides, so we'll be completing this. Mostly we will see that any change in the guideline is there, or and we will not go through the guidelines already present, so which are applicable in the same things, evidence. So let's go into the sepsis. Is a life-threatening organ dysfunction caused by dysregulated host response to infection, and sepsis and septic shock are major healthcare problems which is killing millions of people around the year each year. world each year. So this definition holds the same. Next slide, please. So we here in 2021 for hospitals and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high risk patients, and standard operating procedure for the treatment. So they have added one is standard operating procedures for the treatment. So here last time it is a BPS. Okay. Now the it is strong recommendation, moderate quality of evidence for screening, and strong recommendation, very low quality of evidence for the standard operating procedures. This is because this recommendation has become why it has become important is the as you identify the patients early, the mortality is decreased and morbidity also is decreased and the length of stay also is decreased in these patients. So in they have compared SIRS, QSOFA, SOFA, News and News scoring system, and they found that early identification of these patients with early identification improves the outcomes. Okay, next slide, please. No, previous slide. When I say next slide only, you go next slide. Otherwise, don't move. Okay. This is a new recommendation. We recommend against using QSOFA compared to SIRS, News, or Muse as a single screening tool for sepsis or septic shock. It's a strong recommendation. Moderate quality of evidence. So here they compared, as I mentioned to you, as screening with these the things and which improves the mortality. But most commonly, we found that the QCFI is most commonly used. It has only three components. So of these three components, like respiratory rate, blood pressure, SpO2, so these components will be degraded only when there is a gross organ dysfunction is there or the patient has decompensated significantly. So by using this QSOFA, this patient's mortality is once you identify that this QSOFA is too deranged, the mortality is going and morbidity also is going to be high. That's the reason why they said that this is not a superior thing in compared with the other scoring system, which is a strong recommendation and moderate quality of evidence. Next slide, please. So these are also new recommendations, but we suggest measuring blood lactates. So this is 2019 they have added, but they also continued in 2021. And we suggest, so here the lactate will go further into the lactate. This is a weak recommendation, low quality of evidence. And we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. So weak recommendation, low quality of evidence. So we all know that Andromeda shock trial compared lactate clearance with CRT normalization. So they did not find any difference. So they found that the overall mortality is less in a capillary refill group when compared with the lactate group. But when they have overall compared between these two groups, CRT group versus the lactate group, they did not find any statistical significance. So they have given that if you don't have a lactate, resuscitate these patients as per with the capillary refill time. Is a weak recommendation, low quality of evidence, but you can resuscitate this patient also with the capillary refill time. If you have a lactate, you can follow the lactate also with this. Next slide, please. Yes. So same recommendation, sepsis and septic shock are medical emergencies, and we suggest guiding resuscitation to decrease lactate in patients with elevated lactate level or not using serum lactate. Is a weak recommendation, low quality. The recommendation is the same recommendation. So next recommendation is here 2021 sepsis induced hypoperfusion or septic shock. We suggest that at least 30 ml per kg of IV fluid crystallite should be given within the 3 hours of resuscitation. Previously, it was a strong recommendation, low quality of evidence. Now it is a weak recommendation, it's a low quality of evidence. As you know that process, arise and promise trials, the average volume of the here, they did not find any improvement with a 30 ml per kg fluid resuscitation when compared with the reverse trial. So that suggests that the resuscitation you have to do, you have to assess the volume requirement for the patient and give resuscitation than just giving a bolus of 30 ml per kg IV fluid of crystalloid in a resuscitation. Okay. So another recommendation is we suggest using dynamic measures to guide resuscitation over the physical examination or of static parameters alone. So this is a weak recommendation, very low quality of evidence. So last time also it's a weak recommendation, low quality of evidence. But this time it's a weak recommendation, very low quality of evidence he has used. You can use a stroke volume variation, pulse pressure variation, and use a stroke volume or echocardiography wherever it is available. Next slide, please. Yeah, please, over to next speaker.
Thank you, sir. And these are for mean arterial pressure. These are the same guidelines as 2016. For adults with septic shock and vasopressors, they recommend an initial target mean arterial pressure of 65 millimeters of mercury over higher map targets. It's a strong recommendation and moderate quality of evidence. For adults with sepsis,
no, here before that. So in these patients, what happened is when there are many trials has come where comparing between the 65 mmHg versus more than 65, like 70, 75 and 80, 85 mean arterial pressure targets. They did not improve the outcomes. Only they found that the vasopressor requirements are increased because your target is high, and which can cause a more vasoconstriction and more organ failure in this patient. So 65 mmHg is reasonably a good target, even if it's a patient is having a hypertensive or a CAD or any type of medical CKD. All the patients, I think 65 is a good target and it's a strong recommendation. Next slide, please. Please go ahead.
For adults with sepsis or septic shock who require ICU admission, we suggest admitting the patient to the ICU within 6 hours. As per the study evaluated, 50,322 emergency department patients admitted to 120 ICUs. Mortality increased when emergency department stay exceeded 6 hours. Among hospital survivors, the delayed admission group had a longer hospital stay, higher mortality, and higher rates of mechanical ventilation and central venous catheterization. For adults with suspected sepsis or septic shock but unconfirmed infection, we recommend continuously reevaluating and searching for alternative diagnosis and discontinuing empiric and antimicrobials if an alternative cause of illness is demonstrated or strongly suspected. This is best practice statement. And updated recommendations. In 2016, they recommended that administration of intravenous antimicrobials should be initiated as soon as possible after recognition within both septic shock and sepsis without shock. But in 2021, they updated for adults with possible septic shock or a high likelihood of sepsis, they are administrating antimicrobials immediately, ideally within 1 hour of recognition. In 2016, they told after identification of septic shock and sepsis without shock. But in 2021, if there is suspicion of high likelihood of sepsis also, we can start antibiotics. Strong recommendation, low quality of evidence for septic shock. Strong recommendation, very low quality of evidence for sepsis without shock. For adults with possible sepsis without shock, we recommend rapid assessment of the likelihood of infectious versus non-infectious causes of acute illness. In 2016, they recommended that administration of intravenous antimicrobials should be initiated as soon as possible for after recognition of septic shock and sepsis without shock. In 2021, for adults with possible sepsis without shock, we suggest a time-limited course of rapid investigation, and if concern for infection persists, the administration of antimicrobials within 3 hours from the time when sepsis was first recognized. And one more update, for adults with a low likelihood of infection without shock, we suggest deferring antimicrobials while continuing to closely monitor the patient.
Yeah, here I'd like to just mention that if the patient, see what happens is when the patient is not having septic shock, he has given an antibiotic up to 3 hours as a target, because a lot of studies has mentioned the sepsis, as you all know that sepsis can be because of viral, bacterial, fungal, anything. So when the patient can look like sepsis with a non-infectious also. So he is suggesting that look into whether if it is not, if the patient is not in shock, look into the patient can be a non-infectious. If the patient is infectious, you can give an antibiotic up to 3 hours also. He has given a time, because this is based on on the studies mentioning, even they have a good randomized studies where they are mentioning, they have seen that head to head comparison in septic shock patients, each hour delay increase the mortality. But if the patient is having an infection not in the shock, the you up to 6 hours also there is no major decrease in the mortality if you give antibiotic. So they have restricted it to up to around 3 hours as a antibiotic in a patient who is having an infection, who is not into the shock. So that doesn't mean that delay the antibiotic. You please continue the antibiotic treatment, but this is a few differences he made from the recommendations. Thank you. Please go ahead.
Next, Dr. Pratusha will take over.
Yeah.
Regarding biomarkers to start antibiotics, the guidelines are same as 2016 guidelines. For adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to the clinical evaluation alone. It is a weak recommendation, very low quality of evidence. 3 randomized controlled trials were done and they have a direct evidence by meta-analysis of the 3 RCTs. They found no difference in short-term mortality or length of stay or length of hospitalization when using Procal plus clinical evaluation instead of clinical evaluation alone. And the next updated recommendation is we recommended empiric broad spectrum antimicrobial therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock to cover all pathogens, including bacterial, fungal, viral in 2016. And in 2021, it was subdivided into next following guidelines. That is for adults with sepsis or septic shock at high risk of methicillin resistant staph aureus. We recommend using empiric antimicrobial with MRSA coverage over using antimicrobials without MRSA coverage. It is a best practice statement, and they observed that the incidence of MRSA has been decreasing, but when the patients are at high risk of MRSA, like having recent IV antibiotics or intravascular catheters or any colonization or prior infection of MRSA, they have high risk. Using MRSA antibiotics is preferred without MRSA coverage because it decreases mortality. And for adults with sepsis or septic shock at low risk of MRSA, we suggest against using empirical antimicrobials with MRSA coverage as compared with using antimicrobials without MRSA. So this is a weak recommendation and low quality of evidence. And they found if they are not at high risk of MRSA, using MRSA antibiotics itself increases mortality and also increases antibiotic resistance and other complications like C. diff infections and all. So if there is low risk of MRSA, it is better to avoid MRSA antibiotics. And these guidelines are same as 2016, that is for adults with sepsis or septic shock and high risk for MDR organisms. We suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agent, which is a weak recommendation, very low quality of evidence. And for adults with sepsis or septic shock and low risk for MDR organisms, we suggest against using 2 gram-negative agents for empiric treatment as compared to 1. That is, if they are for high-risk MDR organisms, we suggest using 2 gram-negative, and if they are for low-risk MDR organism, they suggest 1 gram-negative agent. And for adults with sepsis or septic shock, we suggest against using double gram-negative coverage once the causative pathogen and susceptibilities are known. This is a weak recommendation, very low quality of evidence, and this was borne out in a recent systematic review with meta-analysis of 10 RCTs, and there is no difference in mortality or other patient outcomes between mono versus combination antibiotic therapy in adult ICUs. Results from a largest randomized control trial included meta-analysis, that is a comparison of moxifloxacin and meropenem versus meropenem alone in a low endemic resistance setting. And the results were consistent with the same meta-analysis, like there is no difference in mortality, whether using double gram negative coverage or single gram negative coverage when susceptibilities are known. But there are several heterogeneities in the patient characteristics and antibiotic resistance and local antibiotics also.
So, what he says is, if you have a less MRSA suspicion, don't give, and which itself because of the antibiogram, the resistance increasing in the resistance patterns, and also you can have the other reactions. One, and the other side effects. And second thing is here, interestingly, you know that based on the other few studies, it suggests that don't use a double gram negative, but when as an empiric, when you are having low suspicion, but you can even in the when you have identified the pathogen and resistance pattern also. But I think in the XDR organisms, I think as she mentioned, XDR organisms and high risk patients like neutropenic patients, shock patients, I think that depends again on the clinician to go for a combination therapy. But other than that, I think we can it is okay with a gram negative, single gram negative organisms. Yeah. So for adults with sepsis or septic shock at high risk of fungal infections, we suggest using empiric antifungal therapy over no antifungal therapy. So here the recommendation is a little weakened recommendation when compared with the 2016. So in the 2016, what they have mentioned, only one statement they have mentioned for all antibiotics. We recommend empiric broad spectrum antibiotic with one or more antimicrobials for patients presenting with sepsis or septic shock to cover all likely pathogens, including bacterial, potentially fungal or viral. So this is with a good recommendation, they mentioned it. But here now what he is saying is, for patient with sepsis or septic shock at high risk of fungal infection, we suggest using empiric antifungal therapy or no antifungal therapy. So there was a studies on empiricus therapy study where they have given a empirical antifungal for suspected patients and of antifungal empirically with the placebo when compared with the no antifungal agent. They did not find any difference in the mortality or morbidity differences. But when a patient who is having a febrile neutropenia, so they recommended that they took a group of patients and they found that febrile neutropenia and also patient not responding to 4 to 7 days with the broad spectrum antibiotics and the high risk of having fungal diseases as per their antibiogram, or if the patient is having ICU where is a high infections, or patient transferred from some hospital who is having high infections of fungal. In these patients, you can start an empirical antifungal therapy in these patients. For the next recommendation for adult with sepsis or septic shock at low risk of fungal infection, we suggest against use of antifungal therapy as per the same recommendation. Next slide, please. Yeah, next slide, please. Hello. I think the recommendation is 22. No, next 32. Yes. Okay, fine. 32. Recommendation 32. Yeah. For patients, so let's look into the concentrate on these blue lines only. For adults with sepsis or septic shock, we suggest using balanced crystalloids instead of normal saline for resuscitation. Previous statement was we suggest using either balanced crystalloids or saline for fluid resuscitation of patients with septic shock or sepsis or septic shock. But here he's saying that we suggest using balanced crystalloids instead of normal saline for resuscitation. So he is replacing normal saline with the balanced solutions. So we have seen the split trial, which did not show any, the multi-center double-blind randomized trial, which did not show any difference. We also have seen a SALT trial, which did not show any difference, and a SMART trial, which is a single-center multiple patient with a crossover study, which showed low mortality, low ICU length of stay in balanced solutions when compared with the normal saline. We also have seen recently another trial which did not show major difference, but the recommendation is a little higher grade when compared with the last time. He says that use balanced crystalloids instead of normal saline for a resuscitation. Next slide. Yeah. Next recommendation is for adults with sepsis and septic shock, we suggest against using gelatin for resuscitation. Here another recommendation, we in 2016 we suggest using crystalloids over gelatins when resuscitation patients with sepsis or septic shock. That means what he is saying the last time is you can use gelatins, but don't use gelatins early. You can use crystalloids over gelatins. But here for adults with sepsis and septic shock, we suggest against using gelatins for resuscitation. That means I think gelatin should be out of our ICU at present as per the present recommendation. So there is a RCT which was done with between crystalloids, gelatins, and also balanced crystalloids. They found that there is no difference in the mortality or a mortality between the gelatins, crystalloids, or balanced crystalloids. But they found that there are few adverse effects of gelatin, which were reviewed by the meta-analysis, which demonstrated higher risk of RRT, increased risk of anaphylaxis, and affects hemostasis compared with the balanced and other crystalloids. So these three are, because of these three risk factors, there is no mortality or morbidity differences, but there are higher RRT, anaphylaxis, and hemostasis problems. That's the reason why they said that we suggest against using gelatins for a resuscitation. Next slide, please. So for adults with septic shock and cardiac dysfunction with persistent hypoperfusion, despite adequate volume status and arterial blood pressure, we suggest against using levosimendan. We all know that once the patient is having a hypoperfusion because of septic shock, patient the older trials like SCVO2 is SCVO2 was there, and which where the shock is that SCVO2 is not targeted, then we used to start on dobutamine. In the similar way, what he is suggesting is the levosimendan compared with levosimendan, dobutamine. There is a lot of comparisons with adrenaline and levosimendan, adrenaline and dobutamine, noradrenaline and dobutamine, noradrenaline and levosimendan. So they suggest that there is no difference in when you use whether a dobutamine and levosimendan, but a lot of people started using levosimendan because mentioning that there is a less tachycardia, less myocardial oxygen utilization by the patients, and so that the outcomes will be better. So he has given a recommendation that with a cardiac dysfunction with persistent hypoperfusion, despite adequate fluid status and arterial blood pressure, we suggest against using levosimendan. Next slide, please. Yeah. For adults with septic shock, we suggest starting vasopressors, preferably to restore mean arterial pressure, rather than delaying initiation until a central venous pressure is secured. So here the study, there was as you know that there was a study, many studies were done, and there is a RISE trial. One of the RISE trial has showed that if you want to put a vasopressor only in a patient who is having a central line, which delays the starting of vasopressors, where the mean arterial pressure still low before starting vasopressors, then the patient outcomes, patient mortality increases. That's the reason why he says that. So peripheral cannula is there, you start immediately vasopressor. The target is mean arterial pressure of 65 mmHg than the central line or the peripheral line. You say so. Target mean arterial pressure of 65 so that the patient outcomes are much better. So when they compared with the vasopressor starting with the central line and the peripheral cannula, obviously they found that there is a delay in vasopressor initiation and achieving a mean arterial pressure of 65 mmHg in a patient who they decided to put on a central line in a shock patient. So there is insufficient evidence to make a recommendation on the use of restrictive versus liberal strategies in the first 24 hours of resuscitation in patients with septic shock, sepsis and septic shock, who still have signs of hypoperfusion and volume depletion after the initial resuscitation. Here, what was the recommendation previously? We suggest 2016 using balanced crystalloids or saline for fluid resuscitation of patients with sepsis or septic shock. But here, the recommendation is different. So till now, we know that we don't restrict the fluid if the patient is having septic shock and requiring fluid resuscitation. So patient requires a fluid or not, we assess with the different modalities and we give a fluid. But here, this was one of the studies done in Africa, especially in patients who has a dengue patients who were having a shock. Here they found that the resuscitation with fluid, increased resuscitation, increases the mortality and organ failure. And with that evidence, we know that if you are resuscitated in a dengue shock syndrome patient, the mortality is very high in a patients who are in a shock and with a multi-organ failure. And over that, the top of the fluid resuscitation increases the more mortality. And again, with this study, they took few studies and few randomized trials, controlled studies they done. They found that there is no major difference if you are the statistical significant difference when you are restrictive studies versus a liberal strategy in first 24 hours of resuscitation. But be cautious, because if you are completely restricting the fluid, the patients can go into multi-organ failure, the sepsis or severe vasodilatation, you have to fill the patient. So here we have not graded the recommendation, but there are few studies. He is suggesting that, see, ultimately this found what was, we all know that ultimately if the patient is having a less fluid, overall cumulative balance is less, the mortality and morbidity will be decreased. So based on that concept is coming, but at present we don't have a restriction of fluid recommendation. So please resuscitate your patients well, but don't over resuscitate the patient. I can suggest that. Next slide, please. For adults with sepsis-induced hypoxemic respiratory failure, we suggest use of high-flow nasal cannula over non-invasive ventilation. So this is as the COVID has bought this HFNC. So this HFNC, I think in a hypoxemic respiratory failure of other causes also, there is a good number of studies showing that HFNC is better. You can use but here the difference between the HFNC and NIV is, NIV here the respiratory muscle support will be there with a non-invasive ventilation. There will be a PEEP can be given through the non-invasive ventilation. Pressure support also can be given with a non-invasive ventilation. I think these are the problems with the HFNC. But I think we also, we all are anesthesiologists, we need to look into the oxygen toxicity also. We all know that if the patient is having oxygen levels high in the alveoli, there is a gross difference between the A gradient in the between the alveoli and the blood. There can be a high oxygen toxicity if you are supplementing higher oxygen in these patients. But here use of HFNC is a good evidence, quality of evidence, the good suggestion, and there is a insufficient evidence to make a recommendation on the use of non-invasive ventilation in compared to invasive ventilation for adults with sepsis-induced hypoxemic respiratory failure. I think there is no, they have not graded this recommendation, but they say that there is no major in hypoxic respiratory failure. There is no indication sepsis-induced. Next slide, please. For patients with sepsis-induced severe ARDS, we suggest using VV ECMO when conventional ventilation, mechanical ventilation fails in experienced centers with an infrastructure in place to support its use. I think we should have a good protocols when we are starting on ECMO in the patients. So they suggest that there is no recommendation on ECMO last time, but there is a significant use of ECMO and lot of studies has published on ECMO. I think they have put on a recommendation on a good quality of evidence on an ECMO. And the next is for adults with septic shock and ongoing requirement for vasopressor therapy, we suggest using IV corticosteroids. Again, that is around 200 mg per day. That is a standard dose they have recommended. Here, 2016 statement, if you see, we suggest against using IV hydrocortisone to treat septic shock patients if adequate fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. If this is not achievable, we suggest hydrocortisone up to 200. But here, what he's saying is, for adults with septic shock and ongoing requirement for vasopressor therapy, we suggest using IV corticosteroids. So, what is ongoing therapy? So, they found that ongoing therapy means you give fluid. Ultimately when you want to start a vasopressor is when your fluid resuscitation is completed. But now the target is mean arterial pressure is 65 mmHg. Don't wait for the vasopressor also to start until your fluid resuscitation is completed. The goal is you put a peripheral line, start vasopressor as soon as, so that your one side you have to do a fluid resuscitation, other side you have to give a vasopressors and maintain target of 65. When do you want to start steroid is if an norepinephrine or epinephrine dose is 0.25 mics per kg per minute for at least 4 hours after initiation to maintain a target mean arterial pressure. Still, if the dose is more than 0.25 mics per kg per minute, you start on a hydrocortisone in this patient. Standard dose is 200 milligrams per day. That is usually we give around 50 milligrams 6th hour. Next slide, please. So there were lot of recommendations has come on ARDS. Maybe I think 15 to 20 recommendations. They skipped the recommendations because there is no major difference in the ventilatory supports in that ventilatory support. So we have skipped that recommendation. For adults with sepsis or septic shock, we suggest against using polymyxin B hemoperfusions. So last time in 2016, there was no recommendation grading the use of blood perfusion techniques. So we have a lot of auxiliaries, polymyxin B, cytosol, lot of perfusion techniques where they remove cytokines, interleukins, and little larger molecules. So, but these were not proven. They did not make any recommendation for blood purification techniques. So here we suggest against using polymyxin B hemoperfusion. This is a recommendation. So next slide, please. Next slide, and this is the last slide. And for adults with sepsis or septic shock, we suggest against using IV vitamin C. So vitamin C, obviously, it is not suggested in patients with a renal failure. And usually vitamin C in combination with thiamine in combination with hydrocortisone, we have seen studies which have shown the improvement and decrease of mortality and morbidity in these patients. But here, the vitamin C alone also there was comparison of studies which did not show any major mortality or morbidity difference. So for adults with sepsis or septic shock, they suggested against using a vitamin C in these patients. Thank you. Sir, over to you, sir. David, sir, over to you.
So you will have another recommendations later.
No, these are almost completed, no, sir, because the change in the recommendations, all the recommendations we told. Because major recommendations on feeding and thromboprophylaxis, all of first at like Feeding, there are no major recommendation. Analgesia, sedation, there is no recommendations. Thromboprophylaxis also, there is no recommendations. Old should be followed. Head and elevation, ulcer prophylaxis, glycemic control, all the recommendations holds the same. All 2016 recommendations. So we have described about the change in the recommendations that we have discussed.
So all the further recommendations are same.
Same, yes, sir.
Yeah. Thank you, sir. Thank you very much, all three speakers, for making a clarity about the present recommendations and the previous recommendations of sepsis and septic shock. So I have a doubt on the initial screening of sepsis. What you said, you need not wait till patient gets hypotension. As per Q-SOFA score, suggests 3 like hypotension less than 100 systolic and respiratory rate is more than 25 and altered mental status. That means patient already in septic shock, right?
Yes. Yes.
So that is not the tool for screening the sepsis.
Yes.
So you said it is not superior over Q-SOFA. Q-SOFA is not superior over SIRS, MUSE or MUSE. Then what is the recommended screening for identifying the sepsis?
Yes, sir. So here those are also like other organ failures. See, sepsis, as per the sepsis definition, these are life-threatening organ dysfunction caused by the dysregulated host response. So here only 3 parameters are there: altered sensorium, blood pressure, and respiratory rate. So here it is covering altered sensorium neurologically, and blood pressure, and respiratory rate. So cardiovascular and respiratory. So this is a Q-SOFA is a best thing when these patients develop something over normal patient developing these things in the ward. The Q-SOFA can be identified. But here, if the patient has come even in the ward also, the other things like, so what we see temperature in the MUSE scoring system. We see temperature, respiratory rate, heart rate, blood pressure, CNS, that is GCS we see, and any of the change in the parameters, like there is a grading system. So in the change in the parameters, we see it is not a static value. So if any change in the parameter, we look into that. Okay, this is the heart rate is going up, blood pressure is slowly dropping here. So this change in the parameters help us to identify early and the patient is worsening. So this helps us to give a treatment promptly to start an antibiotic or fluid resuscitation. So not to wait until that time. So these are all the MUSE scores. What scoring system you use, sir, in your ward? Sir David, sir.
You are asking either in the ward or casualty?
In a ward.
Ward, okay, but news or MUSE something else, we are using the scoring system to identify the patient who are deteriorating in the ward by increasing the temperature, increasing the respiratory rate, or altered mental status, or decreasing the blood pressure, all these things. But the patient comes to ER with history of fever, cough, or something else.
Yes,
and,
sir.
Till you wait till the patient going into hypotension or altered mental status?
No, not required, sir. Not required, sir. The patient is having fever, fever, tachycardia. Okay, blood pressure might be normal. Respiratory rate might be around 20 to 25, borderline. You see, you check the blood, you check the WBCs, you check the perfusion of the patient, capillary refill time, and you can check the sensorium. You can ask the history of decreased urine output. So history, you can also, when you send the lab parameters, you can correct all these things because most of the parameters will come in 1 hour. So these are all the things where you can look into a combined thing. So he has mentioned that over the SIRS. SIRS means all the criteria comes.
Yes.
So WBC, respiratory rate, heart. So Over that, the Q SOFA is not superior, he is saying. So you overall analyze the patient clinically, lab parameters, organ dysfunction scoring systems, and look into your treatment pattern.
Okay. Any comments or queries from the delegate? Audience?
David sir, just I wanted to add something for the same thing.
Yeah.
The sentence means as you have discussed the same, but what I wanted to say is what he's saying is the Q SOFA is a not sole criteria that you have to use for screening. It has to be combined with either one or two more scores to get the patient into ICU. First thing. Second thing, why they have given a recommendation against Q SOFA is because of its less sensitivity and high specificity. Because of its less sensitivity, they are not able to screen the patients properly. The literature, what they have seen after their initial recommendation, showed that what you said is out of the 100 patients, only 24% of the patients are having a score of 2 or 3. That means it is only 24% sensitive. But
Yeah.
out of 24 patients, 70% of the patients had a poor prognosis. That is more specific. So
Yes.
because of this recommendation, only 24% can be detected early. So it has to be combined with CIRS, MUSE or NEWS, whatever the score. You can use 2 to 3 scores against a single score.
Yeah, definitely. So, any queries from others? Ron sir, Rani madam, Guralakshmi. It is very important sepsis to identify the sepsis and initial registration is very important. And Srinivas sir, one another query. They said initial fluid registration of 30 ml per kg is a very weak recommendation. Why they mentioned 30 ml per kg is weak recommendation? Hello?
Sir, this no? See, this 30 ml per kg recommendation has come from reverse study. So the process, arise and promise trials has come later, and they have not sure. So they also have resuscitated the patient, not using this much of fluid. But before randomization itself, there are few patients received, but ultimately they received around 30 ml per kg.
Yes.
Overall, you see. So as per the reverse protocol of using 30 ml per kg and checking the SCVO2 and again using the 10 ml or 15 ml per kg, these are all the things which caused increasing fluid overload. So here, it was a strong recommendation there. Now here, if you see, you can give a 20 ml per kg or 15 ml per kg also, but see the response.
Yes.
See the response. Suppose a patient who is having also a cardiac issue or a patient who is having a renal failure, who is coming with shock, you give fluid. So it should be given within first 3 hours of resuscitation, he said. But again, you have to check the response, how the patient is responding. It's also a weak recommendation, low quality of evidence. Previously, it was a strong recommendation. Yes.
Oh,
Okay.
hello.
Any comments from you?
Yeah.
Hello. Anna.
Yes.
Yeah. Please go ahead.
See, this recommendation may be depending upon the previous 3 trials that arise and process. All these 3 trials have come, which are all the 3 are against of giving fluids. But there is one surviving sepsis guidelines has commented over those 3 guidelines saying that everybody know how to manage sepsis nowadays. Not even can go into the tertiary, like any remote area also, they know how to manage sepsis because it is almost 20 years of travel. 2010, 2001, I think reverse protocol has come.
Yeah,
so in this 15 to 20 years, we know that sepsis is just a knee-jerk phenomena, give fluid. So patient who got randomized into those trials already received fluid. And after, once they received the fluid initially, adding more fluid to that does not have any positive significance. That's why those three trials, they are against of giving fluids, and same thing might be taken into the surveillance sepsis guidelines. But we should know the patient is directly coming to our hospital or shifted from another hospital, how much fluid he has already received. These things matter a lot before coming to a conclusion whether to give fluid or not. Still, I go with, like, if the patient fresh coming to our hospital having a septic shock, better to initiate fluid resuscitation first, or as per 30 ml per kg body weight, and as Dr. Srinivas sir rightly said, follow up that lactate or your dynamic parameters, and the patient is responsive or not responsive. These things can be fine tuned, and will be deciding whether to continue fluid resuscitation or not.
Yes, sir.
Sir?
Agree, sir. Completely agree, sir. Because these patients who are in the three groups, they overall when they calculate, they are receiving 30 ml per kg.
Now, you mentioned that the recommendation of dynamic parameters to see the fluid response is appropriate or not. Previously, they actually okay, it is a moderate recommendation. Now they said it is a very weak recommendation.
Weak recommendation, very low quality evidence.
Yeah.
So, sir, here what they have used is stroke volume variation, pulse pressure variation, and echocardiography. So echocardiography, static parameters anyway we can't see. So here we have to see a stroke volume variation. So what we suggest using dynamic measures to guide fluid resuscitation, or physical examination, or static parameters alone. So he's saying that to look into the dynamic parameters than this only. There are other parameters also, sir. There is a IVC is there, and also is a cardiac output. So these all parameters we can take and we can look into the thing.
So he said almost ban static parameters, no?
Yeah, there is no role of static parameters, only dynamic parameters. Last time also it's a weak recommendation, low quality of evidence. Now it is weak recommendation, very low quality of evidence.
Yeah, that's what.
Yeah. Sir, any comments, sir? Satish sir or Srinivas?
కామెంట్స్ ఏమైనా చాలా ఫాస్ట్ కంప్లీట్ చేసాం.
Sir, one more thing is the fluids, sir. Fluids wise, still it is like what type of fluid to be given, whether it is a balanced crystalloid versus normal saline. But there are a lot of controversy studies has come up. Even though I'm not talking about these guidelines, recently the basic trial has come and they clearly told balanced crystalloid does not have any positive influence over a normal saline.
Yes.
Sir,
So
the thing is, because the basic trial has come recently, they have not taken into consideration.
Yeah, it's not only the basic trials, sir. So many trials have come against of suggesting balanced crystalloid, because you can take up from the early Christmas trial or chest trial or 6S Scandinavian trial. So many trials have come and some showed positivity towards balanced crystalloid initially, but later on all the trials, even smart trial also, they said there is no improvement in this balanced crystalloid, does not have any positive influence. But still, what we say is there is one thing we can understand, that chloride excessive has a deleterious effect on the overall system, particularly in the renal system. Particularly, it has some 11 to 12 areas where it has a deleterious effect on the nephron. So, overloading of chloride definitely a matter of concern. But what is the cutoff level, we don't know.
Sir,
So
actually, this resuscitation, going to this discussion part, what they are mentioning is the normal saline, as you mentioned, that if you are giving only normal saline 30 ml per kg, followed by again 10 or 15 ml per kg, if you go on resuscitation these patients, if your resuscitation fluid requirement is approximately more than 2.5 liters or 3 liters, at that time you don't continue with the normal saline. You can add a balanced crystalloid in that patient. So that will help us. So after the huge amount of resuscitation with the crystalloid, like a normal saline, which can cause, as you mentioned, like the hyperchloremia, metabolic acidosis, and cardiac issues. But if the resuscitation is less than 3 liters of requirement in the initial phase, I think
Doesn't
there
matter.
is no major difference when the patient is receiving normal saline or balanced crystalloid solutions.
Agreed, sir.
So this, I think this we need to look into that aspect than only directly going into the balanced solution.
Yes, sir. Understood.
Majority people they are afraid of giving lactate in septic shock patients whenever there is a rise in the lactate levels already. So that is one reason they are starting. They are not understanding the regular lactate will not increase the lactate levels. Yeah. Yavana, what do you say?
Yes. So as long as the hepatic system is working properly, ringer lactate does not have any extra burden over the lactate.
Yeah. Or even it will not increase the potassium
It
level.
does not. It does not increase the lactate as per se.
And also it will not increase the potassium levels.
Yeah.
Theoretically, it is better to give a balanced solution, but as per the choice and the institution's protocol, I think it will differ.
So overall,
What is
you
this?
should not give more than 2 liters, right? No, all agreed for that.
Yeah. So again, here comes Dr. Srinivas sir. Here comes the problem with the normal saline versus balanced crystalloid. Then maybe one thing is costly. So
Cost
if there is,
same cost, sir.
if there is no much advantage of balanced crystalloid proven advantage, maybe cost matters.
Sir, cost kuda almost 100 rupees ento unnattu sir.
Sir, if you are taking ringer lactate, is not of much cost. If you are taking plasmalite, plasmazole, all these things, then it is costly.
Yeah, understood. But the ringer lactate is a balanced crystalloid. I don't know.
Near balanced, sir.
Yes.
Yeah, that's all.
Yeah, poor balanced.
So what I'm thinking is balanced crystalloid means which is having like acetate or bicarbonate.
Acetate and
Solution having any solution instead of chloride. The chloride negative ion content has come down. Chloride has brought up to around 90-92 or 100, and remaining 50 is being balanced with acetate or lactate, or acetate or bicarbonate.
yes. What
That's
about
what, no, plasmalite,
albumin? He mentioned albumin, 5% albumin after the continuous registration.
Now, present recommendation says to give albumin if you are using high volume of resuscitation.
Volume is more than 2 liters or 3 liters.
5% albumin.
No change in the recommendation, sir. Same.
Another question. You mentioned about against using the MRSA if there is a very less chances
Low
of
risk.
having MRSA. So how do you initially decide that this patient is having very low chances of having MRSA infection?
See, very low. See, high risk groups we can identify. So high risk groups is one, a patient, as we discussed, the neutropenia patients or a hospital acquired infections. If your antibiogram is showing that if these patients has high chances of MRSA, or in your community the MRSA is high, or a patient transferred from other units, or a patient is having a
Central line.
not responding at central line. So these are all the patients who we have calculated our MRSA gram positive patients are approximately in our unit is 20%. Whole hospital. Of that, MRSA is hardly around half. That around 20% to 25% of that. So gram positive. So MRSA, if you take into that picture, hardly around 5% of the patients are having in our hospital is MRSA. So, but when the patient is in shock, high risk, definitely we need to start. But remember that you need to de-escalate the patients.
Yeah, definitely we will de-escalate after seeing the response and getting blood culture reports. But initially, when patient in shock, so better to give MRSA coverage, right?
He is mentioning that if you are suspecting low risk, don't give.
Sir, I have a question.
Yes.
Hello.
Amma,
Yes, sir.
So one more thing is now dual gram-negative coverage in HDR. Why? How it is justified, sir?
Sir, yeah. See, even though there is XDR organisms, so the XDR organisms in a patient who is stable and unstable. I want to classify this into two group of patients. One is stable patient, a patient who is having a fever, urinary tract infection, but he is on or a pneumonia, who is on a 2 or 3 liters of oxygen. So this type of patients who is hemodynamically stable, I would like to go with a monotherapy, sir, in these patients. But a patient who is in the septic shock patient, because the organ perfusion will be less. In this type of patients where there is an XDR organism, I would like to go with the combination therapy. Even though there is no major evidence, but would like to go with that.
How it helps, sir?
Helps, sir, the additive effect, sir. The possibility of additive effect only. Because we don't know that. Yeah.
But previously, I think there is one study supporting that for Pseudomonas infections, 2 different group of coverages are required, but that is also being proven that it is not a correct statement.
Yes.
They
Yes, sir.
came down to single therapy is enough rather than a dual therapy for Pseudomonas.
Yes.
So there is some therapies like Acinetobacter baumannii, there is a synergy should be there, like adding any sulbactam, rifamycin, bactrim, something that was in the vogue in early 2000. But that is also being proven that it is wrong, not necessary of a combination synergy therapy for a Acinetobacter baumannii also MDR.
Yes.
So having known this much, and what is the role of giving a dual gram-negative coverages when the patient is having a septic shock with an XDR suspected organism? What is the advantage of giving 2 gram-negative antibiotics in such patients?
Sir,
primarily you can take
this is you are mentioning about empiric or treatment?
Empiric only.
Empiric you can have a broad spectrum, no, sir.
Even then, 1 gram,
are...
meropenem covers everything. No, meropenem covers most of the gram-negatives, except very few bugs, which are also rare bugs.
Sir, suppose if there is an XDR organisms, the meropenem will not cover.
No, when you are telling that XDR organism, you are talking about single organism.
Yes.
I'm not. It's not a broad spectrum then.
Sir, this XDR organism. Suppose if you have grown, and now most common is Klebsiella. So
Klebsiella MDR.
Klebsiella is a MDR XDR organism where.
So I wanted to go meropenem and
only sensitive to cholesterol. Okay, sir. If it is only sensitive to cholesterol. Okay. So if it is only sensitive to cholesterol, if a patient who is already in the hospital, in the ICU, where we have a higher chances of Klebsiella, we can add on. If the patient is after 4 days, if the patient has developed again a pneumonia patch or a new onset of septic shock, then we can add in colistin for that. But if a patient who is having a urinary tract infection, who is sensitive only to colistin, patient is stable, his blood pressure is stable and everything is stable. If you are thinking still having a fever, WBC elevated, having an infection, you are not thinking that is a colonization, you can go with a single. But if the patient is in shock, then the perfusion to the other organs and this is a little confused status. At that time, would like to go with the other antibiotic combination. Yes, sir. Srinivas, you are telling something.
Sir, if you are taking it as an XDR, obviously it may be sensitive to either colistin or minocycline or something like phosphomycin or these bugs, and it is better not to use a single therapy because to prevent the resistance, primary thing is to prevent the resistance, is better to give a dual therapy, dual coverage.
But in a stable patients, I don't think
if your organism improving with your carbapenem, then there is no point in escalation. If your organism is not improving and you have to use colistin, it's better to use a combination therapy. That's I'm saying.
These patients obviously will be resistant to carbapenems. and if the patient is stable and having an infection, I think see, adding another antibiotic, there are two things. One is, yes, resistance will increase, but there might be a side effects because of the drug.
David,
So avoid it.
Using a colistin monotherapy. Using a colistin monotherapy
Usually
is
I
not.
am not, but we have to consider for the cost and same time. If the patient is, I don't still, I am now I am not happy with the synergetic effect.
No, we have some time to discuss further.
Yeah, now or
Now only.
yeah, if
Regarding
yeah,
what, Satish?
The same thing, sir. Continuation of this dual antibiotic.
I think we will choose another platform regarding antibiotics.
Okay.
Of
Okay, sir. Thank you.
XDR and all these things, better,
Right.
because it's a big topic and needs more time to discuss, right?
Yes, sir. Yeah. Thank you, Srinivas, sir.
Okay. Thank you, sir,
Thank you.
Srinivas sir, and what is the name? Pratyusha and so thank you very much for
Thank
hello,
you, sir.
Srinivas. Thank you, sir, for a lot of information and inputs given from the
ముక్కులో ఆక్సిజన్ ఉంటే ఎలా
viewers
వెళ్తారు?
and audience. We will close this session today.
ఇప్పుడు నడవదు కదా మీతో పాటు.
We will close the session today and we will come with another new topic from the same group. Srinivas will continue same no for the next.
Yes, we will continue. We put an agenda and we'll continue.
Yeah, thank you, Sinu.
Okay, we will continue the same surviving sepsis campaign guidelines.
Surviving sepsis campaign guidelines అన్ని కూడా స్టేబుల్ అయిపోయినాయి. If you wanted, we can have a discussion on a monotherapy, combination therapy, as Satish sir discussed. We can have a discussion on that next class.
Yeah, and again same Chicken Hospital, Hyderabad, they are going to talk on monotherapy or dual therapy.
Tell about reflect.
Sir?
We will be doing a reflect in Vizag in December, second week of Saturday, second week. So I think we'll have a physical platform and also online platform. So we'll come up with so every year we release a brochure on the day of Dashra, most auspicious day. So I think this year also we'll release it. And we'll come up with details soon. The complete agenda will come up. Thank you. Thank you, sir. Thank you all.
Thank you, sir.
Thank you, sir. Once again, Dr. Srinivas.